Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
I'm Desiree Chappell, your host and anchor, and I'm joined today by Editor-in-Chief of TopMedTalk, Monty Mythen. Monty, hello again.
Hey, Desiree.
We have a very special guest with us. Monty, do you want to introduce?
Yes, we're delighted to be joined by Dr. Dan Martin, who's a consultant, mainly in intensive care at the Royal Free Hospital in London, but also a colleague of mine from University College London. We allegedly share an office some days, which means Dan's got his own office. Is that right, Dan?
Absolutely. It's very nice it is too.
And many of us know Dan and know his voice from TopMedTalk
right.
with regards to extreme Everest and climbing high mountains. Dan summited Everest. He's famous for having the lowest recorded levels of oxygen in a paper in the New England Journal of Medicine. And Dan, another reason you're famous is you've been part of the team at the Royal Free, but also part of the international team of critical care doctors that have treated Ebola patients and treated Ebola patients successfully.
Absolutely.
Yeah. Could you tell us a little bit more about that? And then I think Desiree's got some questions about it.
Okay. So my involvement with the Ebola work is through the Royal Free Hospital, as you say, which is the designated centre for treating patients with viral hemorrhagic fevers in the UK, and my role is the delivery of critical care to those patients. We have an isolation unit that they go to in a special part of the hospital, but when they arrive there and things become difficult, we have to mobilise intensive care up to this isolation unit and care for the patients. So we were involved with the 3 patients who were British patients who were tested positive with Ebola and treated in the UK. And as part of that, we're part of a larger WHO group managing patients in the developed world with viral hemorrhagic fevers.
And prior to that recent round and the world getting together and trying to treat Ebola, when we'd been previously told it was untreatable, it turned out that it's not necessarily a completely fatal illness.
No, not at all. And we had difficulties in the run-up to treating these patients because there was scepticism that you could survive Ebola once you'd gone into multiple organ failure. But to us, this is the job that we do. We look after these patients usually. We've looked after patients with Lassa fever and Crimean Congo hemorrhagic fever previously. Ebola was new for our team, but we felt that there should be no difference in treating these patients than any other patients with an infective cause to their illness. Clearly we have to be doing that in a very safe way, not endangering the staff or the team, but this is a viral infection, and given good basic intensive care with some specialist input from experimental therapies, there's no reason why we couldn't cure these patients of their illness.
So Dan, it's highly contagious, the disease.
Absolutely.
So what happens when you're at work? How do you manage that?
So we have a specially built unit within our hospital. The patients are managed within what looks like a plastic tent. It's called a Trexler Isolator. So the staff are outside the tent and the patient is within the tent. And this is the system as we have used successfully on our unit for about 40 years or so now, and no member of staff has ever been infected using that system. And what you can see now is there are more modern versions of this Trexler system, a sort of mobile plastic cube, if you like, for managing patients in this way. So we use that system instead of perhaps what you're more familiar with is seeing people dressed up in what we call PPE, personal protective equipment, the sort of head-to-toe protection. We don't use that. We put the patient in the isolator instead, and for us that works very well.
So you're not wearing a big hazmat suit?
No, not at all. So it's quite the opposite of the images you see on the news, which is fine if you're treating very small numbers of patients. So we can treat 1 or 2 patients maximum. Out in the field in West Africa, this system is not going to be possible. If you're treating hundreds or thousands of people at once, then it's back to the standard PPE approach to things where the healthcare workers are protecting themselves and the patients are free and open.
What type of training is involved with this, and how do you get kind of everyone on board and talking about the team approach. I mean, obviously communication has to be good and all these different things. So
there's an enormous team involved in caring for these patients, and it starts right from the moment that we have to go and repatriate them from another country. This is not often diagnosed in country, although sometimes it is. Frequently these patients are brought back from West Africa, typically, with the diagnosis. We work very closely with the Royal Air Force, who have a specialist team who go out and collect the patient, and we run drills every year for receiving a patient. So an actor plays the part of the patient, and we run through the whole drill of a patient in what we call a patient isolating transport isolator, bringing the patient through the hospital, up a special lift into the unit and transferring them into the isolation area. And we go through that process in fine detail, making sure that we don't expose members of staff or members of the public, because the hospital still has to function as a hospital during that time, to any risk at all. And then I run through with my ICU staff on a regular basis how to manage these patients. We run simulations, simulating intubating patients, putting in intravenous lines, cardiopulmonary resuscitation. And we run these sessions on a regular basis so that everyone is at least familiar with what may happen, because we never know when the next patient's coming. When the call comes, they'll be there within 12, 24 hours, and we need to be ready for it.
Yeah. I would imagine there's some continuity, so it's the same people on the team, but are you always bringing trainees in and new staff, or how do you kind of manage?
Yeah, we have a core of us who are doing this the whole time, and then obviously people come and people go, so we have to sort of manage that by retraining people, which is why we try and train these people once, if not twice a year, to keep up their skills and familiarization with the unit. But it's a difficult task, keeping everyone familiarized with something that they may actually never see if they're only there for a short time in the hospital.
And what is your involvement in the international community with this? Do you do training in other places in the world and teach other people how to use this type of...
Most often people come to us. So this week, in fact, there's a team from Australia coming to the unit, and we'll be able to talk them through the process of what we do and how we do it. And it's not just the practicality of how you may put an intravenous line into a patient, but there's a lot of behind-the-scenes stuff about the logistics and how to manage the rest of the hospital when something like this is going on, which very much goes back to the talk this morning at the meeting, where they emphasize the fact that whilst something as major as this is happening in the hospital, everything else has to continue without being affected by it, because we still have a duty of care to the rest of the patients in the hospital.
So, Dan, do people ever sort of pitch up at the airport with these sorts of diseases? I mean, how's it contained?
Very good question, and I guess ultimately people could be walking through an airport with this kind of disease at any time. As you know, there's an Ebola outbreak currently in West Africa, and it only takes a sort of 12-hour flight or so to be in the country. The incubation period of these sorts of diseases is anything up to a week or so. So you may not know that you're even infected with a disease like this until you're in the country already. It's less common for us to be alerted to anyone sort of coming through Heathrow, if you like, with a disease. What tends to happen more is that people present to their local hospital. They have, symptoms which are not particularly specific. They have fever. They feel a bit lethargic. Usually the trigger is a recent travel history. So anyone with that travel history to a sort of high-risk area, then they'll usually get on the phone to us or one of the other sort of national advisory services as to whether they should begin testing for one of the viral hemorrhagic fevers.
And from the isolation perspective, before they know that, how do they treat that patient and react to that patient? Because otherwise you're going to be scaremongering and isolating everyone who's travelled who's got a bit of a fever.
Absolutely.
So that's me gone.
Absolutely. What we're in the process of at the moment is setting up a new system throughout the UK under the guise of high consequence infectious diseases, so that every hospital in the country will know how to initially isolate someone should they feel the need to, and also who to contact and what information they'll be required to give. And then there'll be a much more streamlined process of getting a patient who's suspected of having a viral hemorrhagic fever, or perhaps one of the airborne high consequence infectious diseases, which are in many ways more frightening with airborne spread of a disease, to get them into a regional infectious diseases centre prior to going to one of the now allocated high-level consequence disease specialist centres.
Dan, you said there's an outbreak currently in West Africa. Is there any learning from your experiences and the global experiences that's translated into new treatments that's now finding their way back to West Africa?
I think the key things that we learned, everybody focuses really on the experimental therapies that are available. These are expensive and difficult to deploy, and actually the evidence behind them is weak at best. So I think defocusing on that is good for in the first instance, but actually focusing on the things that made a difference may be more deliverable in a developing country, which is just the implementation of very good basic care for these patients. So attending to fluid requirements, electrolyte requirements, prophylactic use of antibiotics to stop secondary bacterial infection. These were the things that killed people during Ebola. Dehydration, electrolyte disturbance, renal failure. All of these things are preventable. But what you have to understand is there's no real capacity to deliver intensive care in many of the places that the disease is rife in. So it's not an ideal situation.
So where you can deliver intensive care, good basic intensive care and not giving up is the secret, if you can do that.
Absolutely. We a sort of conglomerate of investigators, or not of clinicians who were involved in treating these patients in a developed, resource-rich environment. We published our findings in the New England Journal of Medicine, and what was very clear from that was if you can deliver intensive care to these patients, it is effective. Which poses the problem: how do we do that in a developing country?
Wow, so some more lessons to be learned today again. So, Dan, thank you so much for sitting down with us. That's an enlightening conversation. I'm glad we could talk about that.
You.
So,
Dan, thank you very much.
Dan, thanks.
Thank you.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.